I wanted to start off kind of just by letting you give me your brief, let's say, 2-minute assessment of where we're at right now.
Yeah. So right now, in terms of the case counts in Clark County, we've had 359 cases and 21 deaths. We've had 13 hospitalizations, including 2 in the ICU. Total tests have been done so far. We've had is around 4,000, actually 3,999. But that doesn't represent some of the point of care tests. Those tests that can be done in that don't get sent to the lab. Those little machines are done point of care. The negative tests don't all get reported. So, but it looks like around 4,000 tests, and we've had 359 cases and 21 deaths. A lot of the 70 of the cases, 359 cases have been in long-term care facilities. We've been particularly concerned about over the past, since we've been dealing with this, and more recently, cases in congregate settings and people who are at risk. So, for example, long-term care facilities we're particularly interested in, and where we've actually done a partnership with the Vancouver Clinic. If we have a case in a resident or a staff person in the long-term care facilities, we've got a great partnership with the Vancouver Clinic that they're doing universal testing on everybody in such long-term care facilities. We're concerned about the unhoused population, and we're also working with the Vancouver Clinic to begin testing symptomatic people who are unhoused or in shelters. And we've worked with our Department of Community Services to identify a motel. And I think we've mentioned this before, but where we'll be, for people who are unhoused, who are cases, we have isolation rooms there. And for their close contacts, we'll have places to quarantine them at the motel. So we've got that in place. We've got the other setting we're concerned about is the jail, and we've gotten a point of care testing machine for the jail, so they'll be testing symptomatic inmates there. So in terms of the disease itself, the numbers continue to increase, but it looks like the increase is flattening out. The rate of increase in the number of cases is from looking at that metric, it looks like it's flattening out. And the emergency room visits had dropped, look like the emergency room visits for COVID-19 like illness, which is fever, respiratory symptoms like cough and shortness of breath, and a negative test for flu. It looks like emergency room visits are trending down, as well as hospitalization. So that, we look at a variety of metrics when we're trying to figure out what's going on here. The other thing, the modeling that's been done by the University of Washington is kind of like a weather prediction in a way. They're based on disease models here. Gives us some hope that the state of Washington will not be exceeding either its hospital bed capacity or its ICU, critical care bed capacity. One of the reasons for these physical distancing measures is not only to prevent death, but it's also to avoid having an overload of our healthcare system and, hospital beds and ICU capacity. Testing capacity is better than it was, continues to get better. As I mentioned earlier, we don't have a complete view of testing because we don't have all the negative test results for those point of care tests, although we've asked providers to do report those, and at least some of them are reporting them. So we're working on that. Testing supplies are getting better. So the number, I believe, like, for example, Peace Health is now testing all hospital admissions. The Vancouver Clinic, I already mentioned, is helping with testing in long-term care facilities and homeless shelters. Legacy Go Health has got a fair amount of testing capacity as well. I mean, basically the situation is such that anybody who's symptomatic and who needs a test in Clark County should be able to get one. Where there's still some issues around personal protective equipment, particularly gowns. Gowns are, I mean, all these issues that we've had over the past few months, like masks, gloves, respirators and all that were supply chain issues, and a lot of them have gotten better. But for some reason, gowns continue to be a premium. And that's especially concerning in, some of the long-term care facilities where, we have concerns about it, and gowns have been still in short supply. And for the ones that are available, they're ridiculously expensive. So we're still working on that. We work with our partners, Cresa, to procure supplies, but gowns continue to be a challenge for us.
Let me ask you about one of those assisted living facilities, Highgate, because I'm sure we've seen the reports that a pretty significant number of cases, and I believe around a third of the total deaths have come out of that one facility, right? What can you tell us about that?
Yeah, so 7 of the 21 deaths have been in Highgate. So we had I believe the first case, and I have notes somewhere here, but I have it pretty well off the top of my head, was around April 5th in a staff person. And then there was another case in another staff person, I believe, on April 8th. And so we began working with the Vancouver clinic to actually do testing of everybody in the facility, universal testing, both staff and both staff and residents. And we found, let me see my notes here, because I have the exact numbers here. So I have them somewhere here. Yep. We ended up having 26 total cases, 18 in residents and 8 in staff. And I should say so that's testing everybody. The 18 residents were all in their memory unit. So they have both assisted living side as well as a memory unit. They're connected, but they're secure from each other. And we had 7 deaths in the memory care unit at Highgate. We, besides doing the testing, the State Department of Health, as well as the State Department of Social and Health Services, DSHS, have been to the facility. They've gotten some assistance with their infection control practices. The one thing I want to say about Highgate, one other thing I want to say about Highgate is that when they had the first case in a staff person, they notified all the residents as well as the families of residents that there was a case in the facility, and they continue to do so over time. The state folks have been helping them out with infection prevention practices. The other thing I wanted to say about Highgate and about long-term care facilities in general is that not all long-term care facilities are the same. So assisted living facilities like Highgate are more like homes. They're not skilled nursing facilities. And being more like homes, they don't have the same kind of staffing. So they don't have the nursing staff at an assisted living facility that they have at a skilled nursing facility. And given the home-like setting, it always presents challenges around infection control. It's like a home, and people are they socialize and they're close with each other. There's been an issue, I was mentioning PPE. There has been an issue with the supply of gowns. I mean, they're doing the best they can, but gowns, in terms of protective equipment, have been challenging for long-term care facilities, including Highgate. So that's kind of a summary. I think I covered basically all of that. The 7 deaths are really tragic. But the facility is They've been inspected by the state. The state didn't find any, didn't cite them or anything, or have, find particular issues. But like I say, in an assisted living facility, it's like having a case at home, and you've got people at risk there. So that's been a concern. Well, that's one of the reasons why at any of these facilities, if we have a case in a staff person or in a resident, we'll be testing everybody. I went on and on there. I apologize.
That's okay. Let me ask you a real quick question. We asked some of our readers to send some questions for you. One of them I thought was interesting, and it should be a fairly quick answer. They wondered why, if somebody goes in experiencing symptoms and they get tested and they show positive for the flu, that there wouldn't also be a test for COVID-19. Their assumption was that you could potentially have both. Is that possible?
Yeah, and I didn't say people didn't get tested for COVID-19. So hopefully somebody goes in, and is symptomatic and they have symptoms compatible with it. They, at this point, they'd be tested for COVID-19 as well. And I would tell you, we're not in the flu season anymore. So if somebody goes in with symptoms like that, they should be tested for COVID-19. But yeah, I'm glad somebody asked that question, because one of the things I said a few months ago, when we were getting into this, is that people should really get their flu shots, not only to, obviously to prevent the flu, but also, you get a double whammy with, in flu season with COVID-19. Get the flu shot. If we could eliminate the flu or reduce the flu, that helps preserve hospital bed capacity and ICU capacity. So I think it's a great question, and yes, you can have them at the same time.
Okay. The other question that relates to hospital capacity is, obviously we instituted these stay home, stay safe, or stay healthy order, social distancing, bans on large groups, things like that, to flatten the curve. The goal was to flatten the curve to allow our hospitals to not be overwhelmed, to have capacity. I'm hearing increasingly from people say, well, our hospitals are not only not overwhelmed, they're in large part ghost towns, because it seems like a lot of these other cases have dried up. Now, I know that they are going to be allowed to do certain non-urgent care and non-essential or previously non-essential procedures. In your estimation, what would you say are the main barriers remaining, especially here locally in Clark County, to lifting some of the restrictions that we've had in place?
Yeah, I think that's a great question. And actually, there's different reasons for the hospital census to be down. I think a lot of people are concerned about going to the emergency department. For example, emergency visits are down in general because people are afraid to go in because they're afraid that they're going to catch COVID-19. And I think those are, I understand why people feel that way. We actually got a message out with our hospital partners telling people if they need to go to the ED, if they're having crushing chest pain or something and they need to go to the ED, or they're having symptoms of a stroke, for example, they should go to the emergency department. Our hospital partners have done a really good job. I'm glad I'm getting this out there. Our hospital partners have done a really good job of ensuring safety in the emergency department. So people, I understand people are concerned about COVID-19, but if they need emergency care, they should get that. I'm looking forward to having some of the, in terms of the other, what are called elective procedures. Not all elective procedures are elective. I mean, depending on what you're having done, for example, some like heart valve surgery that, you don't have to have, yesterday, but, you're on the list to get that, being able to move some of that up and be able to start elective procedures, I think will actually help people in terms of their health. Those are one of the first things, the access to elective surgeries. I think the governor is going to be opening up. The caveat to all this, and you've already mentioned this, is timing is really essential, because if we back off on the physical distancing measures too soon, COVID-19 is still in the community. It's pretty contagious, and we can see an exponential rise. So the timing on this is pretty critical. But I support what the governor is doing in terms of removing restrictions on this, and more elective procedures, however we want to term them, will be available.
Let me ask you, because obviously we know that a lot of people have died from COVID-19, but there are also growing concerns about the effects of an ongoing shutdown or economic recession in terms of things like mental health, suicides, loss of financial security, potential loss of healthcare coverage if you lose your job. Does your department have any tools or metrics that you can use to observe any of those ancillary situations, such as through death certificates, or how would you track the kinds of effects that we're seeing from the shutdown? Is there a way to gauge, is more harm being done by the continued shutdown than might be done from the virus, I guess is what a lot of people are asking us to find out.
Yeah, well, cause and effect is always an issue. Like, let's say we were to see more suicides, for example, saying that it was caused by COVID-19 is a little bit difficult to say. We have the ability to look at this in terms of, for example, death records that you brought up. There takes time for the reports to be done and the records to be entered. We don't, and the data to be validated. So, we'll be looking at those issues over time. I think there's a lot to be learned from this, but I'm not going to have an immediate result in terms of the death records, because in terms of the way they get reported and the fact that the data have to be verified and checked for accuracy takes some time. So they're not immediately available. I would say, considering, the issue about mortality, we've already had over 60,000 deaths from COVID-19 in the United States. And that's equivalent, and that's in a little bit over a month. You might recall that the first few cases of COVID-19 in the United States, I believe, were in early March. So we've had over 60,000 deaths. 60,000 deaths occur from the flu in the worst flu year. Like we get, you can get, you get thousands of deaths every year in the United States from flu, but 60,000 in an entire season would be a worst case scenario that we've had with influenza. We've already had 60,000 deaths from COVID-19 in a little bit over in a bit over a month, and the deaths are continuing, and that is in spite of all these fairly rigorous physical distancing measures we've had. If we hadn't been doing that, we're likely to have, over 100,000, 200,000 deaths from COVID-19. So this is something that's really serious. I think we're still learning about the mortality. I know that there's some argument. Some people are saying, oh, this is no more, serious than influenza. It is significantly more serious than influenza, just by the sheer number of deaths that we've had. Is the mortality rate, we're still looking at that. I understand that we don't have a great denominator because we've had inadequate testing over the last several months, but based on the data we have so far nationally as well as internationally, it's significantly more lethal than influenza. And the concerns, at least in some of the states, I think we've been really good about flattening the curve here, but the overwhelming use of overrunning of hospital capacity and ICU beds that we're seeing on the East Coast, that is an incredibly rare event that we've ever seen with influenza. So this is significantly different than and significantly worse than in terms of mortality than influenza was. I think the other point that I'm concerned about in terms of keeping being really careful about how we ease the physical distancing restrictions is that we still, in spite of the number of deaths we've had, we still have had a very small proportion of the population infected. And so most of us are still susceptible. So if if we're not really careful in our timing about this, and if we're not really careful about, you've heard that to be able to restrict these physical distancing measures, we're going to need to have a really robust public health response that includes, case investigation, identification of close contacts, and then a quarantine and active monitoring, calling those close contacts every day, like we did with measles last year. If we relax physical restrictions too soon, distancing restrictions too soon, without having that contact tracing system in place, we can see a pretty quick and steep rebound in terms of the number of COVID-19 cases. And that kind of stuff is what keeps me up at night. So we can get on a fast track again if we're not careful about our timing.
Let me ask you real quick. I have two more questions I want to get to, so I hope we have time. The first one, antibody testing. My understanding is that's not happening around here yet. Do you know differently on that? And then if you can, just in 60 seconds, talk about, we've seen some studies that some of the tests that are out there aren't particularly reliable. Explain for folks maybe a little bit about these antibody tests and what they mean and what we should take away from them.
Yeah, so I'm going to do this as quickly as I can. There are two types of tests. One are the antigen tests, and I'm going to quickly explain what an antigen is, A-N-T-I-G-E-N. Antigens are actually the organisms that cause disease. They're the foreign invaders to our body. So COVID-19, well, actually the name of the virus is SARS-CoV-2. COVID-19 is a disease that SARS-CoV-2 causes. That's the antigen. Antibodies are the chemicals that our bodies make when we're attacked by an antigen, when we're attacked by a germ like SARS-CoV-2. Antibodies are the chemicals that our bodies make to help fight the infection. So you've heard the term serology. So the antibodies are found in the serum, part of the blood, and serology is the test of the serum that measures the antibody levels. Antibodies have promise and antibody testing has promise in several ways. One is, if you test the entire population for antibodies, you can identify who has been infected and who might be immune. And you could actually, if you have good data on this and the tests are good, you can actually use the antibody or the serology test to determine whether somebody's immune to the disease. For example, during the measles outbreak, for people who like teachers who are being excluded from schools where there are measles outbreaks, and if they couldn't remember whether they'd been vaccinated or not, we're able to get serology tests on them, measure their antibodies, and say, oh, you're immune to measles, you can go back and work. So that's kind of the promise, one of the promises they have. The other promise that serology tests have is that they can identify people who we may be able to get antibodies from, people who have antibodies, and give them to other people to help fight their infection. Here's why, so they have promise, but here's why they're not being used. And I believe the University of Washington is doing some studies with them. There's some studies that are being done around the rest of the country, but these tests have not really been validated yet. And one of the big problems with these tests is that they have a high false positive rate. And what I mean by that is, so when you're testing for COVID-19, for the virus that causes COVID-19, it's a coronavirus. And there are many other coronaviruses around, and many of those coronaviruses actually cause the common cold. And many of us, if not all of us, have been exposed to coronaviruses in our lifetimes that we've had the common cold. The problem there is that the tests that are available right now, the serology tests that are available right now, have difficulty distinguishing between the coronaviruses that cause the common cold and SARS-CoV-2, the virus that causes COVID-19. So you can get a positive test with serology, a positive antibody test, not because you've actually had COVID-19, but because you've had this other common cold. So you really can't use the antibody test well at this point. It's going to overestimate the number of us who've been exposed to COVID-19.
I've only got you for a short time longer. I would love to get more into that maybe at a later date, but I wanted to ask you because we see this all the time on our Facebook page. You guys post updates, and I don't know how much you personally interact with those, but you know that a lot of the comments about this, a lot of the views have gotten deeply personal, as things tend to do on social media. I wanted to ask you lastly, how have you, on a personal level, dealt with sort of the pushback that you get sometimes from people online?
Great question. One sentence. You also can't use serology tests to determine whether you're immune or not. We don't have that worked out yet, and I want to make sure I get that point across. I don't take any of this personally. I mean, my job as a public health director and a health officer is to protect the public, and in doing so, I need to use the best science I can. I think I don't take it personally. What it is, the problem it is that it's really challenging, and it takes a lot of our time to answer these questions. But I mean, that's part of our job, to get information out. So yeah, I get frustrated at times, but I really don't take. I mean, if that's what the question is, I don't take this personally. I ask myself every day why I do this job, and the reason is to protect and promote the health of the public. So that's what I'm trying to do.
Well, great. Well, I know you've got other meetings that you've got to run off to, but I appreciate you taking a little bit of time to talk with us, and let's do it again soon. All right.
Yeah. Next time I'll try to be a little bit more shorter with my answers. I obviously took up a lot of time. So.
I'll believe it when I see it, Dr. Melnick.
Okay.
Thank you, sir.